Good morning, everybody. Today I will explain which are the predictable protocols to close diastemas. They seem to be easy cases, but they can have hidden pitfalls since we have to avoid the increase of overbite. My patient had a low smile and a severe deep bite at the beginning of the treatment. Intraoral records show a class 1 relationship, upper and lower diastemas, and a steep curve of span, which requires an anterior intrusion and a posterior extrusion to be solved. X-rays analysis reveals a skeletal class 1, an hyperdivergent skeletal pattern, a mild proclination of upper and lower incisors, an increased overjet, and a deep overbite. I planned 2 sets of aligners to fix this case, and total treatment time was 10 months. In the upper arch, I wrote to my technician to start the anterior intrusion after anterior proclination as always. Of course, I over-treated both the anterior intrusion and the anterior proclination. Furthermore, I planned an anterior retrusion during posterior expansion in order to close maxillary central diastema. As we saw in my previous video, for hypodivergent patients, we should plan an anterior intrusion adding a reciprocal posterior extrusion thanks to the use of intermaxillary elastics. So, about the lower arch, we can have 3 types of curve span according to the sector of the arch involved and the difficulty of resolution. In the first case, only lower incisors are overwrapped, so the correction of the vertical position is normally easy. In the second case, we have the upper eruption both of incisors and of canines. In this occasion, I think it's better to apply a frog staging to obtain an anterior absolute intrusion, alternating the intrusion of incisors and canines every 4 aligners. Finally, an occlusal curve which runs from molars to incisors requires the extrusion of premolars and first molars. In this case, it's better to use button cutout and ask the patient to wear elastics to help the extrusion of the posterior sector, and it was what I did for this patient. Obviously, with fixed appliance, it's easier to apply an anterior intrusive force directed along the longitudinal axis. We can place an entire reverse curve arch wire, adding a metallic ligature or an elastic chain from canine to canine in order to avoid the space opening between them. Of course, in order to level the curve span in presence of diastemas is desirable, because for every millimeter of that curve, 1 millimeter of space is required. So, here's my tips for the bite management. Apply an efficient transversal and sagittal arch development. Plan a strong posterior anchorage during incisor proclination, and provide an adequate staging of movement of incisors. First, the roots are removed from the cortical bone, and then a movement of intrusion-retrusion and simultaneous lingual root torque is applied. Now, let's analyze the specific chip features I used for this case. Traditional horizontal attachments were used to avoid lack of intrusion of centrals. Pressure areas were applied to level the curve span by improving control of anterior intrusion and premolar extrusion. Finally, horizontal attachments are applied on the first and second premolars to provide anchorage for anterior intrusion. Every time you have to close the diastemas, don't forget to ask for 3 final aligners with power chain effect. Look at his after images. He had a smile arc improvement and a mandibular advancement, as we can see on his X-ray superimposition. Intraoral final records show the diastemas closure and the bar resolution. Finally, this is his before-after comparison. I hope you find my video useful, so if you want to improve your skills with aligners, don't forget to visit Smart Aligner Service website.